examination of jugular venous pressure and also about the AI, let's talk about the multivalvular disease. Uh, Multivalvular disease, from the point of view of many of you, is quite important. Uh, in the examination, many times a case of multivalvular disease is kept, and mostly kept as a long case. So it is important to understand what is expected out of the examinees in a patient with multivalvular disease. Multivalvular disease have two components. There can be many times what we use is patient is having a mixed valve lesion and patient is having a multivalvular disease. A patient may have involvement of more than one valve, it becomes a multivalvular disease. There can be involvement of mitral valve, involvement of aortic valve, which is quite common in rheumatic disease and also in certain other disorders. Tricuspid involvement is not uncommon. There can be a involvement of a single valve, and the single valve can have two lesions. There can be a stenosis and regurgitation. And many times in the exam, it is asked, what is the patient having? Is there a involvement of the mitral valve? Is there a involvement of aortic valve? Which lesion is dominant? And let's say that's what I will try and address. So combination of stenosis or regurgitant lesions on two or more valves, or mixed lesions of stenosis of regurgitation on same valve is common, and usually that is what is kept in the exam. It is not uncommon to see involvement of two valves in more than 40% cases of rheumatic heart disease. Functional incompetence of the tricuspid valve is quite common as compared to the organic tricuspid valve disease. And what is also important to know is when you will see patients with multivalvular disease, when you see a patient with only one valve involvement versus two valve involvement, you will start finding that the incidence of tricuspid regurgitation increases if there is a multivalvular disease. Organic tricuspid regurgitation is not infrequent, and particularly after we started having a lot of data from echocardiography, we know that organic tricuspid regurgitation also is common. And in patients with significant mitral valve disease, the incidence of organic tricuspid valve disease is quite common. It may not be possible to clinically accurately judge all the lesions, but a fairly good idea can be made out about the presence of the lesions and about their severity. And that's what all the clinical medicine is about. We know investigations beginning from ECG, X-ray, and more importantly echocardiography has taught us quite a lot, particularly in the field of multivalvular disease. It is important to understand that the consequences or the findings of specific combinations depend on specific combinations, whether the combination is of MSMR, ASAR, or ASMS, MSPHTR. So the consequences will depend on the specific complications and timing of each lesion. It is possible in valvular heart disease, both lesions may not start simultaneously. There may be a gap between the two lesions beginning. There might have been a patient where there is a history of rheumatic fever at the age of 8 to 10 years, and then again at the age of 17, 18 years. And this patient may develop one valve involvement at X time and the second valve involvement at subsequently. So the timing of each lesion also will determine the clinical picture. The loading conditions, which ventricle has got loaded, the ventricular function, the left ventricular function, the right ventricular function, and both components, systolic and diastolic. So all these factors determine the clinical presentations of the patient. It is important to know the etiology of multivalvular disease. Majority of the times in our country and from the purpose of examination, the etiology which you will see of multivalvular disease is usually rheumatic. I will put it at least in 80 to 90% of the cases, the etiology will be rheumatic. And in those patients, it will be quite common to see that there is involvement of the mitral valve, there is involvement of aortic valve to varying degree, and also the patient has developed some involvement of the tricuspid valve. It can be a functional involvement or it can be an organic involvement. Degenerative heart disease is not uncommon, and degenerative heart disease we are seeing, and particularly in Western world and even in our country, we are seeing a lot of degenerative disease. There is a lot of degenerative aortic valve stenosis which is being seen these years, and also with degenerative aortic valve disease that there can be involvement of the mitral valve in form of a mitral annular calcification. So you can see in elderly patients a combination of aortic stenosis with mitral incompetence. Of course, mitral incompetence in elderly can be due to other reasons. I'll come to that. So that can be another type of case which you can get in the exam. A patient in the age of 60 years or 70 years having findings of AS and findings of MR. Also, degenerative disease can be in form of myxomatous degeneration of the valve. There can be myxomatous mitral valve disease, myxomatous tricuspid valve disease. The other etiology of multivalvular involvement can be sometimes in aortoarteritis. There can be involvement of aortic valve and the mitral valve. In connective tissue disorders like Marfan's, there can be involvement of mitral valve, aortic valve. Rheumatoid arthritis, SLE, these conditions also can involve, but they are less common. Infective endocarditis can involve mitral valve, aortic valve, and of course rarely it has been known to cause even involvement of all four valves. Carcinoid disease, quite uncommon, but if you see a patient where there is an involvement of tricuspid valve and pulmonary valve, a combination of TR and PS and PR, think of carcinoid. Radiation is emerging as a, I won't use the word common, but radiation is emerging as a cause of multivalve disease, and radiation-induced mitral incompetence, radiation-induced aortic incompetence, and in those populations where there are a lot of patients of malignancy treated with radiation, we are seeing these cases. So from the point of view of the exams, the commonest etiology of multivalvular disease will be rheumatic, not to forget the degenerative cases, and some cases of aortoarteritis or connective tissue disorder can come into. Rarely, congenital AV canal defects can have a mitral and tricuspid regurgitation, and at times you may get a case of dilated cardiomyopathy where there is a functional mitral regurgitation and aortic regurgitation, mitral and tricuspid regurgitation because of annular dilatation, and this can mimic like a valvular heart disease. So the background of etiology is important to understand. There are a couple of important things to understand when you see a patient. They are also described in some certain textbook as rules of thumb. And one important thing is a severe lesion becomes more obvious than a mild or moderate lesion. Say for example, there is a patient where the aortic regurgitation is severe. You will get all the signs of aortic regurgitation, and if this patient is having a mild or moderate mitral regurgitation, you may not be able to appreciate it because all the findings will be dominated by the aortic regurgitation. The proximal lesion, or what is called as an upstream lesion, tends to determine the clinical presentation. Example, a patient having mitral stenosis and aortic regurgitation, findings of MS may dominate. Distal lesions are relatively masked. Hemodynamic and clinical consequences of two or more lesions is not what it should be. And very interestingly, we will start thinking that if a patient is having two lesions, 2 and 2 should become 4. It is not always so true, because there are a lot other factors which determine. A patient, for example, having a severe MR and a severe MR, we will expect that this patient should have a large amount of left ventricular volume overload. He should be very symptomatic. That cannot be true. So important to know certain rules of thumb, particularly that severe lesions are the ones which become more obvious, and proximal lesions are the ones which tend to determine the clinical picture. Many times in the exam, you might have missed a given murmur, or you might have thought the X lesion is dominant and Y lesion is dominant, and the examiners may keep asking you the questions, do you think this patient is having this lesion also a little bit? So think over, maybe the dominant finding of other lesion has made you not realize that there was another lesion which was mild. The consequences of multivalvular disease sometimes are that there will be low flow and low gradients. A patient who is having, say, a combination of a mitral and aortic valve disease, and if both are stenotic lesions, these both lesions will produce a low cardiac output, and because of that there can be low flow and low gradient. So you may hear the murmurs which may be less dominant, less prominent. Mixed valve lesion increases flow and gradient. Now if there is a, say for example, a mitral stenosis and a mitral regurgitation, the mitral regurgitation in a patient of mitral stenosis will increase the flow and the gradient, and there may be a systolic murmur and there may be a diastolic murmur which may increase with the flow. And in hemodynamics of these patients, the application of continuity equation may become difficult, pressure half time may become invalidated. So there are multiple things which occur in multivalve disease. I am sure in the echo talk you will be getting more light on this. And any lesions which are upstream lesions can cause a functional mitral regurgitation or functional tricuspid regurgitation. It is not uncommon to see a patient with severe aortic regurgitation because of left ventricular volume overload. This patient may develop a mitral annular dilatation, and there may be findings of mitral incompetence. A patient where there is a pulmonary hypertension, you may get a tricuspid valve incompetence. Now, there are various lesions which we encounter in clinical practice in multivalvular disease. There can be involvement of one valve, and there can be varying degree of narrowing and leakage. There can be a patient with MS and MR, or there can be patient with the MR and MS. Now these terminologies and these descriptions are utilized in clinical practice. You get a case where both findings of MS and MR are present. You will be asked which lesion is dominant, whether it is MS dominant or whether it is MR dominant. There can be a patient where there is a aortic regurgitation and aortic stenosis, and again the question arises whether aortic stenosis is dominant or aortic regurgitation is dominant. In relation to a patient who has got an MS and MR, not only it is important in the exam from the point of view of knowing what a candidate is knowing about hemodynamics and auscultation, it also has a therapeutic bearing. A patient who has got a dominant MS and a mitral regurgitation which is not significant, this patient can still be subjected to a balloon mitral valvotomy rather than sending him for a mitral valve replacement. So this is one of the implications of knowing the specific contribution of a given lesion. Then you can have a MS with aortic regurgitation. You can have a mixed mitral with aortic regurgitation. You can have MS, MR, AR, AS. So you can have various combinations, both valves, and you can add all stenosis, regurgitation you can have. You can have the regurgitation lesion of both valves, aortic and mitral. You can have stenotic lesion of both valves, mitral and aortic. You can have a mitral stenosis with mixed aortic valve disease. You can have a mitral stenosis with organic involvement of the tricuspid valve. Actually, at the time when I was doing my DM nearly 4 decades back, we used to see a lot of cases of triple valve involvement, all organic disease of mitral valve, aortic valve, tricuspid valve. These lesions have become less, but still seen. And functional tricuspid regurgitation of varying degree is common in almost all types of valve diseases. Now let's first come to mitral stenosis and aortic regurgitation. This is a frequently encountered lesion you will see quite commonly. And aortic regurgitation, as we know, increases the preload, and vice versa. The reduction of preload is done by mitral stenosis. And because of this, if the patient is having a tight MS, pulmonary hypertension, which is a common thing to, it will reduce the preload of the left ventricle, will reduce the cardiac output, and which in turn will reduce the peripheral signs of aortic regurgitation. So in patients of tight mitral stenosis with severe pulmonary hypertension, it is important to remember that peripheral signs of aortic regurgitation can be underestimated. So when you get such a case, it is possible that you are underestimating the aortic regurgitation, and that is what is expected from you in the examination. The examiner will keep asking, do you think how much is the AR? Is the AR significant? Can the AR be moderate? And then you start this thing. But if you know the logic behind it, in patients of mitral stenosis, particularly that mitral stenosis which is severe with reduction in cardiac output and severe pulmonary hypertension, where preload has got reduced, you can underestimate aortic regurgitation. The other part, there can be patients of aortic regurgitation, and as we know in aortic regurgitation, you can have, if aortic regurgitation is severe, you can have a mid-diastolic murmur at the apex called as an Austin Flint murmur. Now, how to diagnose mitral stenosis in these cases? This is another question which is asked in the exam. Is the patient having mitral stenosis, or this is a Austin Flint murmur? Now, how do you suspect mitral stenosis in a patient where there are findings of otherwise dominant aortic regurgitation? And if there is an atrial fibrillation, if there is a diastolic thrill, if there is an opening snap, and if there are features of pulmonary hypertension, these findings will favor associated mitral stenosis in a patient of aortic regurgitation. So it is important to know how this combination, which is common, can present, where it can be underestimated, where you can underestimate or overestimate the another lesion. Now, this is an echocardiographic example of a patient where there is a mitral stenosis and aortic incompetence, and this also brings out that there can be limitations of applying pressure half time, limitations of applying continuity equation, and the important thing when you do echocardiogram in combination lesions should be you should look at the valve areas. Mitral stenosis and mitral incompetence is another combination which is common. Etiology, by and large, 95% of times, or I will say 99% of times, of a combination of mitral stenosis and mitral incompetence will be rheumatic. Rarely in these years, actually, with people living longer, I was seeing a lot of cases of mitral annular calcification. There can be patients with mitral annular calcification where there can be mitral stenosis and mitral regurgitation. But mitral annular calcification usually presents with dominant MR rather than having findings of dominant MS, but this is one of the causes it can be. And there is rarely you can have a congenital mitral stenosis, parachute mitral valve and other variants. Now, you will be asked commonly in the exam if there is a mitral stenosis findings and mitral regurgitation murmur, what you are dealing with, whether it's a OS or it's an opening or it's a third heart sound. So you should be ready with these answers. Opening snap is usually louder, it is widely heard, widely audible, whereas third heart sound is a low pitched sound and it is heard with the bell. Opening snap, A2OS interval opening snap is usually soon after the aortic second sound, whereas third sound is usually delayed. So these small things are asked when you see the combination lesions. How do you know this patient is having a significant MR if there is a mitral stenosis present? And these, the findings which can help in that, if you feel that there is a left ventricular type of apex in mitral stenosis, then you suspect that there is an associated MR. There is a pansystolic murmur, wide splitting of the second heart sound. And how do you suspect if the person is having mitral regurgitation? How do you, and at times only mitral regurgitation can have a mid-diastolic murmur, flow murmur in severe mitral regurgitation. Now, if this patient is having atrial fibrillation or severe PH, think of that there is an associated mitral stenosis. So these are questions which may be of less importance in the era of echocardiography. Once you do the echo and you know these things, but this is what have been traditionally asked. It is good for a student to know these. AR with MR is another combination. A patient can be, mitral regurgitation can be, mitral regurgitation can be present due to primary etiology, or mitral regurgitation can also occur in patients of aortic regurgitation due to dilatation of the left ventricle. So this is again a very, you will be asked, suppose there is a patient where there is a severe aortic regurgitation and this person is having some findings of mitral regurg. You may be asked if this mitral regurgitation functional mitral regurgitation or this mitral regurgitation is of the same etiology. Is it of rheumatic etiology? In severe aortic regurgitation, if aortic regurgitation is long standing, there can occur LV dilatation, there can occur LV dysfunction, LV failure, and then it can give rise to mitral regurgitation. And both the lesions, aortic regurg and mitral regurg, can further enhance the left ventricular dilatation and left ventricular failure. There can be load on pulmonary circulation, and also PH and TR can develop in these patients. So in patients of aortic regurgitation, association of MR is not uncommon, and MR can also secondarily occur in these patients because of the functional deterioration of the left ventricle. Presence of atrial fibrillation in patients of aortic regurgitation is usually a pointer to mitral regurgitation being of rheumatic etiology. Aortic stenosis and aortic regurgitation is another quite a common lesion to be seen. Again, the questions are usually the same. How, if there is a patient of aortic valve disease, how significant is aortic regurgitation? How significant is aortic stenosis? And these years in the era of TAVI, it may be important to know if there is a dominant AR or dominant aortic stenosis. If you see in a patient of severe AS, the pulse is high volume, it indicates that the patient should be having a significant amount of aortic component. Cardiomegaly in a patient of aortic stenosis will indicate that there is a significant amount of aortic regurgitation. Usually aortic stenosis will give rise to only left ventricular hypertrophy, there will not be a dilatation. So if you see in aortic stenosis that there is a cardiomegaly, diagnose that there is associated aortic regurgitation. The presence of long murmur, delayed peaking murmur, soft aortic second sound, paradoxical split, conduction to carotids favor the presence of what is called as an organic aortic stenosis in presence of aortic regurgitation. So these are the usual questions in the exam asked in these patients. Patient has got aortic regurgitation, also there is a systolic murmur. It will be asked whether this aortic stenosis is functional or this aortic stenosis is organic. So these there is a small points help to differentiate. Combination of mitral stenosis and aortic stenosis, we don't see these years this combination that commonly. Of course, the picture of rheumatic fever has changed considerably over the years, and we don't see the type of cases which we used to see 3 or 4 decades back, but still we do see some cases where there can be combination of rheumatic mitral stenosis and rheumatic aortic stenosis. This diagnosis can be tricky. To diagnose both lesions clinically can be tricky. There can be low volume pulse and lower systolic blood pressure can occur in either lesion if it is tight and severe. AS can be missed or underestimated in those patients where there is a severe pulmonary hypertension. So if you get such a case, and if the examiner is hinting you whether this patient is having associated AS also, or in a patient of AS, examiner is hinting you whether there can be associated MS, you should understand the nuances, that these are the lesions where combination can be missed on clinical assessment, and these can be the reasons. So you can underestimate or miss aortic stenosis in a patient of mitral stenosis if there is a severe PH which has caused low cardiac output. On the other hand, mitral stenosis can be missed in severe AS. Severe AS softens first heart sound. It elevates the left ventricular end diastolic pressure, and because of the elevation of the left ventricular end diastolic pressure, LV-LA gradient reduces. LV-LA gradient reduces and the length of the mid diastolic murmur reduces. So you can miss or underestimate mitral stenosis. Presence of atrial fibrillation, severe pulmonary hypertension are usually clues to diagnosis of MS in patients of AS. So you should keep these small points in mind which can be of great importance in diagnosing these, and these are also important. Many times even after echo and X-ray and ECG, until unless your clinical thought process is clear, you can miss these lesions. As I was mentioning, these days with longevity in the society and people living longer, there is a combination of aortic stenosis with mitral regurgitation seen not uncommonly. And this is mostly of degenerative etiology, commonly seen in elderly Western world. Even in our country we are seeing cases. Long-standing aortic stenosis causes increased afterload, left ventricular hypertrophy, dilatation, dysfunction and secondary MR with leaflet tethering and annular dilatation. So severe aortic stenosis can give rise to MR only because of severe AS. There can be other reasons of MR in elderly. Along with AS, there can be mitral annular calcification with mitral regurgitation, or there can be ischemic heart disease associated with papillary muscle dysfunction, or there can be a patient where there was a degenerative mitral valve prolapse who has come up to this stage. So the combination of AS and MR, not uncommon, poses a challenge in diagnosis, and also when you will look at the therapeutics. Even these are the patients where TAVR can be challenging, patients of aortic stenosis with mitral annular calcification, or these are the ones where there may be requirement of a double valve therapeutics. This is an example of a patient. If you see, there is a severe degenerative calcific aortic stenosis on the middle panel, and this patient also has got some prolapse of the posterior mitral leaflet, with the result that there is a mitral incompetence and there is a severe aortic stenosis. So this can be a combination of aortic stenosis with mitral regurgitation, which is not uncommon in elderly. Now coming to the tricuspid disease, tricuspid valve disease. Now, as I mentioned at the beginning, that there can be two ways in which the tricuspid valve can be involved. Involvement of the tricuspid valve is quite common in mitral valve disease, with the mechanism of causing pulmonary venous hypertension, pulmonary arterial hypertension, and they get tricuspid regurgitation, what we call as a secondary tricuspid regurgitation. More is the involvement of the two. If you have a single valve disease, double valve disease, chances of functional tricuspid regurgitation increase. We should not forget that organic tricuspid valve disease also is not uncommon. We still do see patients with organic tricuspid valve disease. And tricuspid valve disease in a patient with a involvement of the mitral valve or aortic valve, there can be certain symptoms of tricuspid valve disease which can be pointers to think of tricuspid valve disease. And whether it is a tricuspid valve disease secondary to the left heart disease or primary, the symptoms which can be a pointer to tricuspid valve disease can be, these patients can have symptoms because of certain reasons. There can be reduced cardiac output, and because of the reduced cardiac output, patients may complain of fatigue, effort intolerance. These patients develop right atrial hypertension, and because of that there can be hepatic congestion, pain in the right hypochondrium, congestion of GI congestion, and the symptoms of nausea, vomiting, loss of weight. They can develop fluid retention. There can be pedal edema. There can be ascites, and ascites and pedal edema in patients who are having an organic tricuspid valve disease can be multifactorial, and at times that can be the clue that a patient, despite giving diuretics, is having some ascites, GI symptoms, and these symptoms, the ascites and pedal edema, can be due to various mechanisms: increased venous hypertension, decreased renal perfusion, hypoalbuminemia. They can develop malabsorption syndrome, protein losing enteropathy, cirrhosis of the liver. So if you see such symptoms, there should not be any hesitation in the exam bringing out a tricuspid valve lesion, tricuspid regurgitation or tricuspid stenosis. That will depend on the physical examination, but you must think of that this patient is having a tricuspid disease. Functional or primary, you can discuss. Now, physical findings of tricuspid regurgitation and the stenosis. Again, the tricuspid regurgitation manifests with features secondary to chronic venous congestion, pedal edema, abdominal wall edema, ascites, the jugular venous pressure, and as Ethan was telling, these are the patients where there can be large B wave, there can be A wave if there is pulmonary hypertension, there will be a rapid wide descent in patients with tricuspid regurgitation, slow wide descent in tricuspid stenosis. But of course, slow wide descent is a little difficult clinical finding to appreciate, but what is easy in the venous pressure examination is to find a large V wave and a rapid wide descent. Those are usually easily appreciable. Signs secondary to venous pulsations. Sometimes the venous pulsations may be so strong, venous pressure may be so high that you can have a earlobe sign, pulsations of the venous, pulsations of the earlobe, proptosis. There can be icterus, peripheral cyanosis, cardiac cachexia can develop, pulsatile liver can develop, and the murmur of tricuspid regurgitation is a murmur which is usually heard on the left lower sternal border. The murmur increases with inspiration. Tricuspid stenosis murmur increases on inspiration. It's a superficial mid-diastolic murmur, and the increase in inspiration is also called as a Carvalho's sign. So functional tricuspid incompetence, organic tricuspid incompetence are not at all uncommon. And when you are looking at a context of a multivalvular disease, you will find patients having some degree of tricuspid valve involvement and signs of tricuspid valve involvement. Whereas seeing the combination of MS, AS, TS, that is quite uncommon these years, because we don't see that virulent rheumatic fever and rheumatic heart disease. But organic tricuspid regurgitation is not uncommon. And what is the clinical importance of the lesion severity assessment? Of course, apart from you're passing the exam or you're going for the exam, there is a practical importance. The assessment of the lesion helps in clinical decision making. And there used to be a time when even echocardiography was not available. When I was doing my residency in CMC Vellore, we used to auscultate patients. Patient has tight MS, some aortic regurgitation, and we used to clear the patients for closed mitral valvotomy just based on clinical assessment. So if you are looking at a patient combination of MS and AR, if AR is mild or moderate, this patient, if valve morphology is suitable, you can still send this patient for a balloon mitral valvotomy. If you have a combination of a patient with a MS and MR and aortic valve disease is mild or moderate, you can send this patient only for mitral valve replacement, can follow up the aortic valve lesion. If there is a severe disease of both the valves, aortic and mitral, that definitely requires a double valve replacement. And one should not forget, organic involvement of the tricuspid valve is important. Its incidence increases with number of valve lesions, and if there is a significant organic tricuspid regurgitation, patient is going for surgery, the tricuspid valve should be tackled at that time. I think I'll close here, and I'll be happy to answer any questions if there's still some time left. Yeah.
Good morning, sir. How to clinically differentiate between organic and functional TR, sir?
Good question. Say, between organic and functional tricuspid regurgitation, the most important thing is when we are talking of a functional tricuspid regurgitation, there is a associated left heart disease. Means there is a patient where there is a mitral stenosis or mitral incompetence, and this patient has pulmonary hypertension. Now, when patients are having pulmonary hypertension, we tend to diagnose that this patient is having a functional tricuspid regurgitation. I'm talking mainly just clinical. When you get a patient where there are findings of mitral stenosis or mitral regurgitation or combination, not much of pulmonary hypertension, and you still start having a findings of tricuspid regurgitation, you clinically suspect that this patient may be having a organic tricuspid valve disease. And of course, the finer distinction of functional and organic will come when we do the echocardiogram. We look at presence, absence of pH, and also look at the morphology of the tricuspid valve, where the disease process is there in tricuspid valve, thickening and other things. But strictly speaking, clinically, organic tricuspid regurgitation should be suspected if there is a tricuspid regurgitation murmur in absence of pulmonary hypertension.
exam also, they keep asking assessment of severity of each of these valve lesions. Like any of you have any doubts on that aspect also, you can clarify it from sir. Combinations of lesions. Divedi sir.
And as explained by Professor Satyavan Sharma, another thing is a non-pan murmur. The murmur in functional tricuspid regurgitation may not be pan-systolic murmur. It may be finishing earlier. So non-pan murmur without evidence of pulmonary hypertension. Now you can have tricuspid regurgitation with a organic disease or functional disease both. But once you are having a sustained parasternal impulse, that will go in the favor of secondary pulmonary arterial hypertension induced tricuspid regurgitation. But if there is no second heart sound loud, if there is a non-pan murmur, generally primary murmurs are not that loud, but yes, you can have murmurs. And thirdly, you are having a hyperkinetic type, and you are differentiating between whether it's a secondary or primary, then you should think of this.
Well taken.
Sir, do we need to grade non-dominant lesion in exams?
Can you tell again?
Sir, if in a mixed lesion, if there is one lesion is dominant, that is severe, and other lesions are also present, should we grade them mild to moderate, or like how to do that?
Well, usually, traditionally, they have been, possibly a good term is whether it is significant or it is not significant. But yes, loosely it can be graded as mild or moderate. So the importance becomes is, whether you are having a MS and MR, whether this MR is dominant or whether this MS is dominant. Now, again, dominant, significant, these are the terminologies which are usually used. So for the other lesion to say whether this lesion is grade 1, grade 2, I don't think it's that much important.
And I would say, like in exams, you will be asked, once you tell the complete diagnosis, this is justified. And then you said, why severe MS? Then people start saying only the murmur. Always take the history, positive physical findings into the account, rather than directly jump into the, they are your weapon to justify. So please don't neglect that. Now my questions to all of you, if both lesions, like patient with AS and MS, both are pliable, non-calcified AS, rheumatic, and a pliable mitral valve, and you had subjected for valvotomy, young patient, you don't want to, because valve replacement is again, you are introducing disease by anticoagulation. So although rheumatic BAV, the results are suboptimal, which lesion you will operate first?
AS we will operate.
Yeah. First you will say, I will do transeptal first, because the heparin issue, if anything goes wrong, it will be, and then, and if you hand over to surgeon, then the surgeon, we don't require anything in order, because it's from ways, so whatever is comfort zone, because it's already patient is on CP.
The good thing about multivalvular disease is at least you can make out one correctly also, still you get out of the exam. But the prominent lesions generally you don't miss, whichever is significant. Even associated insignificant lesions you are not able to diagnose also, still it is okay. But you should not miss out very prominent things. Otherwise the examiner will come to know that you have been fed with the diagnosis. So that's important to correlate what findings you have.
Now, yes, combined lesions do present a problem. Now, the important thing there is don't try to make stenosis as regurgitant lesions at mitral valve both severe. They can coexist. But make either of them as dominant. And we are talking only about the mitral valvular involvement. There is no aortic valve involvement. So if there is MS and MR, if you have volume overload, MR is severe, then MS will be mild or moderate. At aortic valve, both can be severe. Now the problem here is that, suppose there is aortic regurgitation, and then you have to talk whether AS is severe or not, or significant or not. Unfortunately, the indicators to say that AS is significant are all those which make it severe as well. For example, if in the presence of severe AR, you are having a forceful, sustained apical impulse, two possibilities, either he is in heart failure or significant AS. Now this significant AS means severe AS, because only that can cause, or aortic carotid delay is also your finding. Aortic carotid delay itself is a finding of a severe AR. Or long murmur, because short murmur can be functional. If you find long murmur, again it is an indicator of a severe AR, severe AS. So, as long as you are not finding the severity indicator of the other lesion, say it is, first statement is, it is very difficult to decide in the presence of this. You are passing the exam, you are giving the examiner a chance to let you through. So tell him that both lesions, particularly for aortic valve, sir, both lesions can be severe. However, I am not finding anything suggestive of significant AS. So I would say that it is probably not hemodynamically significant. But remember that hemodynamic significant AS, if you are able to diagnose, it indicates a severe lesion.